Welcome back to the deep dive. We are really zeroing in today. We're pulling directly from your MSRA revision notes, focusing specifically on vasculitides.
That's right.
Our mission really is pretty straightforward. Take all this info, which can seem, well, complicated, and boil it down. A clear, high-yield overview for you. We want to help you cut through the noise, get a solid handle on vasculitides for your revision, quickly and effectively.
Vasculitides are absolutely crucial for revision, aren't they? They're a fascinating, sometimes quite tricky group because fundamentally you've got the body's own immune system attacking blood vessels, and the effects can be so wide-ranging depending entirely on which vessels are involved. That variability is key.
Right, that variability. Sounds like that's going to be a running theme. So we'll work through everything in your notes, the definition, causes, risks, pathophysiology, how it actually works in the body.
Then differentials, how common it is, presentation, how we investigate, manage it.
And outlook, potential complications, all straight from the source material you're using.
Exactly.
Okay then, let's unpack this. Let's dive right in. The basics. What are vasculitides?
Okay, so essentially vasculitides refers to a group of disorders, the defining feature, inflammation and damage happening to blood vessels. Think of it like the body's plumbing system coming under attack.
Under attack. And what's actually doing the attacking? What's the mechanism your notes describe?
Well, what's really interesting and kind of central here is that it's the immune system driving it. The body's own immune cells mistakenly target the blood vessel walls. This leads to inflammation, destruction of the vessel wall. It's almost like friendly fire causing damage that can then affect the organs those vessels supply.
So the immune system gets it wrong, attacking the very infrastructure it's meant to protect. And you mentioned variability. Does this attack always look the same, target the same vessels?
No, and that's a critical point. This immune attack, this inflammation, it can affect all sorts of blood vessels, large arteries, medium ones, tiny capillaries, even veins. Understanding the variability of the different sizes and types of vessels affected is absolutely fundamental to understanding why vasculitides present in so many different ways. It dictates everything.
Got it. So if it's the immune system going rogue, what triggers it? What's the etiology? Your notes say the exact cause is often unknown, which sounds tricky.
It really is. The origins are described as complex. It's rarely just one thing. It's more likely a combination, a sort of convergence of factors.
Like what kind of factors?
Well, there often seems to be a genetic predisposition. Some people might just be genetically more susceptible. Then you have environmental factors, things in the outside world playing a role. And fundamentally, underpinning it all is some kind of abnormal immune response, a malfunction.
Okay. And are there specific things that might sort of kickstart the process in someone who's susceptible?
Yes. The notes mention potential triggers, things like infections. Certain viruses or bacteria can set it off. Some medications have been implicated too. Or sometimes vasculitides can develop alongside other autoimmune diseases the person already has, like rheumatoid arthritis or lupus.
So a complex mix. Genes, environment, immune system glitches, maybe an infection or a drug tipping the balance. Explains why finding one cause is so hard. Building on that, are there specific things that put someone more at risk?
Yes, your notes list several specific risk factors. Genetics, as we just said, family history, certain genetic markers definitely increase risk.
Okay, beyond the genes.
Environmental exposures are mentioned again, things like toxins, pollutants maybe. Certain infections are known contributors for specific types like hepatitis B or C are listed. And importantly, already having another autoimmune condition like RA or SLE, that definitely elevates the risk.
Right. Inherited risk, stuff you're exposed to, past infections, other immune problems.
Okay.
Let's get deeper into how the pathophysiology, what's actually happening inside those blood vessels.
So the core process, according to the notes, is this immune-mediated inflammation that specifically targets the blood vessel walls.
Right, focused on the wall. And what does that inflammation do to the wall itself?
It causes damage. The inflammation can lead to the vessel narrowing stenosis or weakening, which could lead to an aneurysm or even becoming blocked, completely occluded.
And if the vessel narrows or blocks, what's the downstream effect?
Well, that directly restricts blood flow, doesn't it? And when blood flow to a tissue or organ is reduced or cut off, that's ischemia, lack of blood supply.
Yeah.
And if that ischemia is severe or goes on for too long, you get tissue damage and potentially organ dysfunction.
Ah, okay. So inflammation, vessel damage, reduced blood flow, organ damage, a clear chain reaction starting with that immune attack. And does this process look identical regardless of the vessel?
No. Mirroring the other variability, the notes point out that the specifics of the pathophysiology can differ. It depends on the type of vasculitis and the size of the vessels involved, another layer of complexity.
It really keeps coming back to that variability, doesn't it? Okay, so given that wide range of effects and the fact it's inflammatory, what else might present similarly? What are the key differential diagnoses?
Yeah, this is crucial for revision, obviously. You need to consider other things that cause inflammation or vessel problems. Your notes specifically list infection-related vasculitis, where the inflammation is secondary to an infection, not the primary autoimmune attack. Then there's drug-induced vasculitis, a reaction to a medication. Also, other connective tissue diseases like SLE need to be considered, and various other autoimmune disorders too. You have to cast the net wide initially.
That makes sense, ruling out those other potential culprits. Let's touch briefly on how common this is, specifically thinking about the UK. What do the notes say about epidemiology?
Well, the prevalence and incidence figures, they vary quite a bit. It really depends heavily on the specific type of vasculitis you're talking about. Some are definitely more common than others.
Do they give examples of the more common ones?
Yes, giant cell arteritis. That's the one often affecting older adults, particularly the temporal artery and microscopic polyangiitis are mentioned as examples.
And do we have a complete picture for all types?
The notes are quite clear that comprehensive epidemiological data just aren't available for all types of vasculitis. So we know about some, but the full picture is a bit patchy.
Okay, so prevalence is type dependent. Now let's get to the patient. What might someone actually look like? The signs and symptoms, clinical presentation.
Again, and apologies for sounding like a broken record, but it ties back to that variability. Because it can hit vessels anywhere, the clinical presentation is incredibly diverse. It depends entirely on the specific type of vasculitis and, crucially, which organs are feeling the effects. There's no single standard picture.
So it really is a systemic disease, potentially showing up in countless ways.
Exactly. Your notes list common signs and symptoms you might encounter. Things like general systemic stuff, fever, fatigue, unexplained weight loss, those non-specific things. Then you might see skin issues like rashes or joint pain, muscle aches. But it can also manifest with quite specific organ involvement, neurological symptoms, breathing problems, signs of kidney trouble.
Wow, that's a huge spectrum, from feeling generally unwell to major organ systems being hit. And the notes stress that severity and the pattern of symptoms differ greatly, too.
Absolutely.
So with that broad, sometimes vague presentation and the list of differentials, how do you actually pin down the diagnosis? What investigations are key?
Yeah, making the diagnosis often involves putting several pieces of the puzzle together. Clinical assessment, taking a good history, examining the patient, that's always the starting point.
And what tests help build the picture?
Blood tests are vital. Your notes mention things like a full blood count and inflammatory markers, ESR, CRP, which can show there's inflammation somewhere in the body. Imaging studies can also be really helpful. Angiography to look directly at blood vessels, or ultrasound, depending on what you suspect and where.
And sometimes you need to look directly at the tissue itself.
Yes, often a tissue biopsy from an affected site like skin, nerve, kidney, or temporal artery is needed. That can confirm the diagnosis and help identify the specific type of vasculitis. And the notes also add that other tests might be needed to check how involved different organs are, or to definitely rule out those other conditions on the differential list.
Okay, so it's a combination approach. Clinical picture, blood markers, imaging, often a biopsy for confirmation, all tailored to the individual case. Once you have a diagnosis, what's the management approach? Thinking UK context from your notes.
The main goal really is to suppress that overactive immune response, get the inflammation under control, and crucially, prevent further organ damage.
And how do you do that? What are the main tools?
The cornerstones of treatment mentioned are glucocorticoids, steroids, basically which are powerful anti-inflammatories. And alongside or following those, immunosuppressive medications are often used to dampen down the immune system more specifically or long-term.
Is it a standard recipe for everyone?
Absolutely not. The notes really emphasize that treatment has to be individualized. It depends heavily on the type of vasculitis, how severe it is, and which organs are involved. Tailoring is key.
Right. And is it usually a quick fix?
Often not. Regular monitoring and follow-up are highlighted as absolutely crucial. You need to see how well the treatment's working, check for side effects, and adjust medications as needed, potentially over a long period. Many of these are chronic conditions.
That close monitoring sounds vital for the long run. What about the outlook then? The prognosis for someone diagnosed with vasculitis in the UK?
Well, surprise, surprise, it varies significantly. It depends on the type, which organs are affected, how quickly it was diagnosed and treated, and individual patient factors.
Is it generally quite bleak?
Not necessarily. The notes do offer a positive note stating that with the right management, many cases can be controlled and patients can achieve remission, meaning the disease isn't active.
That's good to hear. But some types are more difficult.
Yes, some types are definitely noted as being chronic, meaning they require long-term, sometimes even lifelong, treatment to keep them under control.
And if it's not managed effectively, what are the risks?
The notes are pretty clear here. Poorly managed vasculitis carries a significant risk of severe permanent organ damage. This can lead to disability and in some cases can be life-threatening. It really highlights why getting the diagnosis and management right is so important.
Yeah, that leads straight into the potential complications. What are the main adverse outcomes listed that you really need to watch out for?
The major ones are all related to that organ damage or dysfunction we talked about. Your notes list key areas.
Yeah.
The kidneys are a big one, the lungs, the nervous system, the heart, and the eyes can also be affected. Damage here can be devastating.
So the complications directly reflect where the vasculitis hits hardest, and I assume the severity varies.
Absolutely. The notes point out that severity depends on the extent and intensity of the vasculitis itself, and specifically which organs took the hit and how badly.
And can you do anything to lower the risk of these complications happening?
Yes, it comes back to management. The notes stress that proper tailored treatment and that regular ongoing monitoring are the crucial preventive measures. It's about catching flare-ups early and keeping the inflammation suppressed to minimize the risk of long-term damage.
Okay, so bringing this all together, we've got this complex group of diseases, often with unknown causes, presenting in myriad ways because they can affect any blood vessel, needing careful diagnosis, individualized treatment, and carrying this risk of serious organ damage. Why is grasping all this, as laid out in your notes, so vital for revision?
Well, I think because it really tests your understanding of systemic illness. It forces you to connect underlying pathology, that immune attack on vessels, with a huge range of potential clinical signs and symptoms. Understanding why it's so variable, why early diagnosis can be tough but is so important, and why management needs to be tailored and monitored closely. It all stems from that core process. It's about seeing the big picture, from potentially subtle clues, and knowing the stakes involved in preventing those serious complications.
That really pulls it together. It's about connecting those dots systemically. Okay, here's a final thought for you to mull over as you revise. We've established the cause is often unknown, and the symptoms can be really broad initially, mimicking other things. How does that inherent difficulty in spotting it early potentially change the course of the disease for a patient? What are the downstream implications for preventing those severe complications we just discussed? Something to ponder on the real-world challenges.
A very important point to consider.
And that wraps up our deep dive into vasculitides, using your MSRA revision notes as our guide.
Hopefully this has helped clarify the key takeaways. The definition, causes, risks, pathophysiology, differentials, presentation, investigation, management, prognosis, and those potential complications.
We really hope this session provides a solid foundation for your revision, hitting the high points from the source material.
Remember to revisit this if you need a refresher, and keep exploring other topics too. It all helps build the bigger picture.
And don't forget, resources like PassThemSRA.com and FreeMSRA.com are there to support you on your revision journey. Keep up the great work.
Absolutely. Keep digging deep.
We'll catch you on the next Deep Dive.